Great. Can everybody hear me? I hope so. If you can, just pop a message in the chat. I'm more than happy to answer any questions at the end of the talk. Just post them in the chat box and Hina and George will moderate and ask them towards the end. So I'm one of the consultant radiologists working at Leicester hospitals. My specialties are neuroradiology and head and neck radiology. And what I've been tasked today is to do several things. Firstly, one, why radiology? And secondly, sort of the day in the life of a radiologist. And that's quite a broad topic, and I'll try and focus in on it a little bit later on. But so first things first, why radiology? And I think the way I break it down is you have to look at what you like and dislike about your skill set and what you're looking for from a career in radiology or a career in medicine, because ultimately you're going to be doing it for 30 years or so. So you're going to want to enjoy it and be able to do it as much as on day one as in your years before retirement. So for me, it boiled down to, I liked being able to make a diagnosis. I like to get to the bottom of the problem and figure out what it is that's causing patient problems. I like the idea of being able to treat things or facilitate the path to diagnosis, either by taking biopsies or samples. And I really liked working in a team. I liked having people to bounce ideas off. I like standing in a group of people or looking at a camera, taking a cheesy photo. I liked the way you need a discussion, because that's what makes things interesting, and really drill down into what it is that will make a difference for a patient. And really the thing that I disliked about my time as a medical student and as a junior doctor was ward rounds and discharge letters. But as I'm sure if you see, the more senior you get, the less of the more routine and mundane tasks will be replaced by other more technical problems, I guess. So ultimately, I think what you need to drill down is what is it? Is it for me? What is it that drives me? And what is it that makes me tick? And in radiology, when you start off with training, there's a very steep learning curve. I think it's still quite a hidden subspecialty. We don't get a lot of exposure during medical school, and there are key aspects that you have to be aware of. So a lot of radiology is all driven by anatomy, your understanding of what's normal and what's not. You'll need to get a basic understanding of physics. So some of your time will be spent in classroom, essentially picking up how the different modalities work and what limitations there are, because then that drives your ability to give advice to your colleagues to investigate, to help them, guide them choose the right investigation, or why something won't work, or how to optimize imaging for patients. And when you start radiology training, there's a lot more responsibility, because you suddenly step up from being the senior house officer to being a registrar, which comes with it, the added expectation that what you say carries some weight and some carries a degree of respect that you understand and know what you're talking about. On the other hand, your patient contact will, depending on the subspecialty you choose within radiology, vary quite a lot. So it won't ever be the same as some of your clinical specialties like medicine or surgery. But in things like breast radiology, you still run your own clinics. You see patients, assess them, speak to them. But it will vary quite a lot, and it will be, on the whole, a lot less than clinical medicine. Work-life balance is very important. Not all, the on-call commitments of different subspecialties within radiology varies a lot, and this sort of is exposed by things like if you're choosing to do interventional radiology as opposed to diagnostics, And it also varies between hospitals. So friends of mine, colleagues of mine have moved away from sort of tertiary centres and work in DGHs. Their on-call commitments are sort of several hours at the weekends, and they do a weekend depending on maybe 1 in 10, so depending on how many consultants are at the trust. So these are all things to consider when you're thinking about choosing radiology and the location you eventually want to end up at. And finally, for me, I mentioned this earlier, I think making a diagnosis is one of the really most satisfying aspects of what I do. Being able to tell someone this is what I think it is, or narrow down to a short differential and say, if you do this, take a sample here, or if you do this test, then I think we'll be able to get to the heart of the problem for the patient. And I think that's really one of the most satisfying aspects of my job. So, a day in the life of a radiologist. This is it's quite a broad question, I guess. It varies very much depending on, again, where you're training and at what stage of your training / career you are. The expectations for a junior registrar differ to those of a senior registrar, and obviously from that of a consultant. And part of it is that's related to how competent you are, essentially. At the beginning, your competence is much reduced, which will be a big step change, I guess, for a lot of trainees, going from being first point of call, or on the ward where the team will be looking to you to make a decision or assess a patient, to being a first year registrar where you won't necessarily know a lot about the imaging modalities that you're being asked about, or why one test is better than another. But obviously, as you progress, some things will become easier, some things will become more difficult. Your ability to practice independently will increase to the point that you pass all your exams and become a consultant. I'll go through each stage as in turn. So I'll start off with junior radiology. The group I envisage a junior radiologist to be would be the core years, so ST 1 to 3. And so a lot of this, like I mentioned before, was bookwork, getting to grips with your anatomy, starting off getting an understanding and being able to interpret things like chest x-rays, getting to grips with how to manipulate an ultrasound probe to obtain images, what planes you need, how this differs between imaging modalities, so what some things look like on ultrasound as opposed to CT, as opposed to MRI. And then a little bit will be on call work. So most of the time in STs 1 and 2, you'll start off, definitely in Leicester, start off as junior on call, taking the phone calls to understand what people are calling the department for, and why, where you fit in and with the patient journey and the route to their diagnosis. And in ST3, you start doing senior on calls, which means releasing reports independently, working overnight as the first port of call, being sort of the liaison between the clinical teams and the radiology consultant on call, and assessing sort of when the patient needs further specialist opinion. And in these years, you're expected to do all that, but also continue on with your postgraduate exams. And typically the first year you will be sitting a pair of exams, one in anatomy, based on being able to identify anatomical landmarks and figures on images across different modalities. So whether that be sort of bony structures or organ systems on CT, X-ray, ultrasound. And then at the beginning of your third year, I know our cohorts have just sat their Part 2A exam, which is your the basic knowledge encompassing sort of all aspects of clinical radiology, whether that be anatomy, different pathologies and how they appear, and basic techniques about how to obtain those images. So next up will be senior radiology. Radiology training varies depending on which subspecialty you have decided to embark upon. If you are continuing with the diagnostic subspecialty, you do 2 years of subspecialty training and finish an ST5. It's all currently it's all run through. So that means when you have interviewed and get a post, that's basically it. The next interview that you will do will be the one for a consultant post. If you are interested in doing interventional radiology, it's again still run through, but you have an additional year. So you finish as ST6, and that's the same whether you want to do interventional radiology, so things like vascular or GI/GU work, or interventional neuroradiology, where you'll spend most of your time at a tertiary neurosciences centre. And as you guessed, because you've acquired more skills and you're developing an interest in a certain organ system, you'll be still carrying on releasing your reports for imaging tests as you were before, but with less and less need to consult senior colleagues and consultants, and focusing more on the organ system you have here. So in my ST 4 and 5 years, I spent most of my time at Queen's Medical Centre in Nottingham, and a little bit time in London, just focusing on neuroradiology and head and neck radiology to make sure I've gained the breadth of experience and seen a variety of pathology, to make sure that I will be comfortable releasing reports on my own now. In these final years, you're expected to pass the final exam, so the 2B, become a fellow of Radiology, Royal Society of Radiology. This is mostly based upon sort of your ability to interpret different scans and discuss them with examiners. And at that point, that's it. You pass all the exams, finish your training, become a consultant. So what's a day like for me? I spend at Leicester, the MDTs are on Monday, so with the multidisciplinary teams, I prep all the images for, review all the images for a list of patients for discussion. So that could be CTs, MRs, this patient had a PET scan, and then discuss them in the meeting to see what's next for the patient. What is it that we think we're dealing with? Staging the patient, so being able to give the team sort of an idea about the prognosis or the most likely beneficial way forward treatment-wise for the patient, what options are available for them. So when they see them in clinic, it guides them as to the direction that they're going to take in counselling a patient about what they can offer them. Another day would be spent looking at, that might be spent on neuroacute work, so assessing what comes through the door in A&E or on the wards. So it could be trauma related. So patient on the right has been, I think, was a young gentleman involved in a road traffic accident. You can see he's got quite a large volume of pneumocephalus, so need to issue accurate reports about the extent of the complications, where surgeons need to be able to focus on to treat. Again, on the left-hand image, patients had a depressed skull fracture, and again, complications arising from that, and who the referring physicians need to refer to. Need a coffee. It's a long day reporting acute scans. The radiology department, like the rest of the hospital, is extremely busy, catching up not only with acute work, so can report upwards of sort of 40 scans a day, and that will just solely be CT heads, and not even counting the MRIs that you have to do. So you have to make sure you're appropriately awake and responsive to what happens or comes through the door next. Stroke is also one of the major things that we are asked to sort out. So reporting the plane scans, and then helping the local mechanical thrombectomy service by looking at their post-contrast studies. Refueling again for the final session of an acute day. Again, so you don't know what will come through the door. This gentleman was, I think, 34 and just come on with a vague history of being unwell and not aware of what it was that was happening to him. So when we looked at the scan, he had this really very dense metal object coming in from his right-hand side of the skull. You can see sort of something on the outside coming in all the way through the middle. And then on the 3D reconstructions, you can see that it's got a pointed end on the inside, and this is a nail that's been driven in by a nail gun. So there's a lot of variety in what we do, and a lot of it is some of it is quite mundane and straightforward, but there are times where you have to be on your toes, and you never know what's going to come through your scanner doors. Wednesdays for me are spent doing outpatient work, so follow-ups from clinics or new presentations that clinicians feel can be assessed on an outpatient basis. This patient has had a long history of seizures and has a port wine stain on his face, and he's got this extensive sort of calcification and atrophy on the right cerebral hemisphere. So this is a classic image of a Sturge-Weber disease. Could be some inpatient work that you have to report urgently. In this case, there's a patient with known TB and got multiple areas of ring enhancement throughout the brain, some representing disseminated tuberculosis. Acute infarcts, sometimes you present on MRIs. Usually these patients will be quite non-specific symptoms. And finally, one of the other large components is cancer and cancer follow-up. So this patient with known GBM that has received treatment, and we're following up to see what the imaging is like after radiotherapy, chemoradiotherapy. Head and neck has its own unique facets. These are AP and lateral X-rays of a cyelogram of the parotid. You can see that we've inserted a little cannula into the duct and injected dye and watched as it goes into the branching system of the parotid gland to see if there's any abnormal dilatation or filling defects to represent calculi. Some of my colleagues in pediatrics or at tertiary neurosciences centres will be looking at things like fetal MRI, so imaging babies who are at high risk to see what their development's like, and enable clinical colleagues to counsel families as to what the projected outcome would be for their pregnancies. Finally, my Fridays are quite hectic, often with an ultrasound list in the morning and catching up with any other acute work. So I'll be scanning patients' necks in the ultrasound rooms, looking at their vocal cords, thyroid glands. Again, looking at the parotids, you can see that the appearances are quite different. Sometimes we'll find lymph nodes that we are a bit concerned about. So we'll discuss with the patient, and then we can take biopsies there and then if we think it's appropriate. So this is the linear core biopsy needle within the lymph node, and that gets sent off to our histopathology colleagues, and then around hopefully prepared and ready for the next meeting on the Monday. And then afternoons will be a mixture of head and neck or neuro reporting, so helping out catch up with any acute work that's on the list. So this patient has quite a large abscess on the posterior triangle of their neck, or it could be quite a gross sinus malignancy that is extending into the orbit and out through the anterior maxillary wall. Or this patient who has a quite large paraganglioma at the right jugular foramen, which has all this characteristic flow voids and intense enhancement after contrast. So the last point I wanted to touch on, I guess, is more for people coming up to their subspecialty applications process, and also as just as a early primer for people who are in medical school or F1, or even those thinking about transferring to radiology. That there's a lot going on outside of just what we do on a day-to-day basis, and one of these is issued by this gentleman, Professor Sir Mike Richards. He issued a report essentially discussing how the NHS as a whole can help achieve better outcomes for patients or provide better care for patients, making patients the centre of what we do and how we go about it. And part of it was that there's a realization that the earlier you get to a diagnosis, the broader your options are for a patient, and therefore the earlier the treatment, the better the outcome. But also in time of pandemic, you want to be able to carry out both your sort of hot site work, so your COVID work, separate from your sort of cancer care separately, so that you don't have patients who are vulnerable to COVID having their treatment delayed because the acute hospital is under pressure from whatever infectious disease is currently around. And the idea is that working, rather than separating out primary care and secondary care, they should be more integrated and form part of integrated care systems and work together to provide diagnostic services to patients closer to them, which broadly is what we should strive to make sure things are best suited for patients. And that means could mean seeing patients with your clinical colleagues next door, imaging them there and then, directing them to a CT or MRI, as well as getting the ultrasound and biopsy all done within a day or a week. And that way patients get to their diagnosis quicker, have it discussed at the MDT quicker, and then see their consultant again following weeks. That's the aim. And the diagnostic hubs where all this activity is projected to be carried out, and is one of the areas that is the focus of how we are attempting to deliver care in the future. So, still interested? Well, what can you do now, essentially? I think there's going to be a talk later on detailing the applications process and what you can do. But looking back at my applications process, what did I do, or what did I do to make sure that this was what I was interested in, what I think will be the right career for me. If you're in medical school, there might be special study components that you can carry out in the radiology department, or if you're in foundation training, taster week is I think basically a desirable component, if not essential, in the person specification. See if there's audit projects or research projects that you can get involved in. There's plenty of courses out there to give you an idea of what each subspecialty is like, or radiology is like in general. And these all give you access to sort of what the hot topics are in radiology, or what the challenges are facing radiology as a whole. And I think the last thing would be to speak to the radiology trainees and the consultants to see what their opinions are and what they feel would be things that you could look into or help you prepare for your applications. So I hope that brief whistle-stop tour gives you a little taster of what things are like, what my routine is, and I hope you enjoy the rest of today's program. If there are any questions, I'm more than happy to take them now.
So thank you for that first talk. We've just had one question from Rachel so far, which is asking what consultant on calls are like.
What consultant on calls like? That's great. I literally did one last week. So I was on for neuroradiology for the entire week. I would carry on with my usual routine that I described earlier, Monday to Friday, but out of hours between 5 p.m. till 9 a.m. I'd have my phone switched on and await any calls. I basically lived my regular life, but just had an extra work phone turned on. I wasn't contacted at all by the registrars, and I think that's probably a reflection on how well they are, how hard they work, and how capable they are by the time that they're on senior on call, that they feel happy to interpret and release reports independently. At the weekends, I came in and did a 9 to 5 report, just checking the scans from the Friday night, and then on Saturdays, the Saturday night scans on the Sunday. Reported a few TIA MRI scans, and that was about it. I didn't get called in at all. It's quite unusual, I think, for a diagnostic consultant to be called in. What else? I think the question will be slightly different if you're speaking to an interventional radiologist. Again, it's not. It partly depends on how I think for the interventionist, what's happened during the day, whether they managed to get everything sorted. But you never know what's going to walk in through the door. But most of the time, it was quite a stress-free and quite comfortable week of on calls. Was there anything else specific that you wanted to know? I know my colleagues who have gone to work at DGHs do fairly similar things. They might have an ultrasound list in the morning, then a few scans, like CTs or MRIs to report afterwards. But it is quite variable. Other colleagues working elsewhere only have to provide ultrasound cover for a few hours at the weekend, and things go to outsourcing companies. So people who work, consultants who work elsewhere, whether that be Australia or America, that report for private company. So it is quite variable, but from my experience, relatively straightforward.
So based on your previous answer, we did actually have a question on the sign-up form, which is, what do you know about applying to radiology training abroad, and is this something that you would recommend?
Oh, I don't know much about applications to training programs abroad. I do know that several colleagues have gone to do fellowships elsewhere, whether that be in the UK or Canada, I think is quite popular, and Australia would be the other place. Those would typically involve sort of like a phone interview, being able to send off your CV, and then probably a further, maybe face-to-face, like online interview. I don't know the details or specifics of interview or applications processes for elsewhere.
Okay, thank you. And the other question we had is, how do you maintain an interest in looking at similar scans?
Yeah, I think this is a question that actually what trainees in radiology ask me, and it's true for. I can imagine that's true for any subspecialty really. How do histopathologists like looking at slides for same pathologies? You don't, or clinicians doing endoscopy. How can you look at an esophagus any differently from the previous esophagus? It's partly to do with one. I think you have to understand at the end of the day, take a step back and think this is a patient. Whether it's normal or abnormal, you want to do the best for them and see that you are giving them an answer to a question. Is there something wrong, or is there something to be concerned about? To the variety that I see in head and neck and uroradiology is vast. The anatomy is incredibly intricate. In the paraganglioma image I showed you earlier, if I'd scroll down further down, because of the region involved, lots of cranial nerves and structures are located at the jugular foramen. So it's all fascinating functional work. So the patient there would have had ipsilateral tongue wasting. They may have also had wasting of the sternocleidomastoid or trapezius on the same side because their accessory nerve is compressed. All these things are sort of a beautiful demonstration of essentially what you learned in the first year of medical school. All these things that you've learned, you can now apply because you can see, you understand it, you can recognize the pathology, you can direct the clinicians to say, you know what, maybe they could have be referred to vascular intervention to embolize it to reduce the size, and then they could then see my clinical oncology colleagues so that they could get radiotherapy to reduce the tumor. I think the tongue atrophy might put the patient at risk of aspiration, so they'll need possibly a salt review to assess what's happening from that perspective. Every patient will have a unique constellation of problems or possible complications that you can help them get on top of if you understand what's going on. And I think that's our role as a radiologist, as a doctor, to be able to envisage or predict what might happen for them. So yeah, that's how I would say what keeps me interested. When you become a consultant, it's not just the clinical work. So I think this is a good example, working with training junior colleagues, making sure that they develop to become consultants and comfortable with what they're doing. It's incredibly satisfying. Research, there's research work that goes on. So we're involved in a national trial investigating necrotizing otitis externa. So that's another aspect. yeah, so there's lots of different things that on top of what you do as a clinician, gives you sort of like a broad range of leadership and management roles um, as a consultant.
Brilliant, thank you. And I think we've just got one last question for you. Oh, two last questions.
Sure.
Which is, what's the scope for teleradiology and how does it work?
The scope for teleradiology is vast. If I give you, so I think we did an audit a couple of years back, and basically within the span of my training, which was 5 years, CT scans had doubled or tripled. This is just for acute work, whereas MR imaging had doubled, and the same smaller rises, but rises nonetheless had increased for ultrasound and plain film. And I think that the only reason those hadn't risen to such a massive extent was because of they basically reached the limits of how many patients you could get through those modalities. And if you think about it, the workforce for radiology hasn't actually increased commensurate to match the demand, complicated by the fact that people are also coming towards the end of their career. So we're not replacing enough like for like. So we're producing lots of scans, but not able to meet the demand, and that's just for the UK. So there are multiple teleradiology companies. Once you become a consultant, you're qualified, you essentially sign up to one or several of these companies, and I think the idea is that you can either go to their sites of work or offices to report there, or they can even set up reporting stations for you at home. And obviously there'll be things about clinical governance, about how accurate your scans are, how many will be double reported, so reported by another consultant, so you get feedback on what you do, and then remunerated for that work. I know teleradiology is just one aspect, but there's also a lot of insourcing. So within trusts, people will be doing extra lists to help catch up, not with just the delays, but also with COVID catch up, essentially.
Okay, and the final question is, do you do? I think Heena's just answered it in the chat for you.
Yeah, so this is from Rachel, isn't it? Do you do many procedures as a diagnostic radiologist, or is it mainly just ultrasound? I would say this depends. This is very variable, and I think Heena will agree. Say for my specialty, most of mine will be predominantly ultrasound based, but that's here at Leicester. I know colleagues who work in Scotland will be doing CT guided biopsies for head and neck spaces. You at tertiary centres, you tend to have your subspecialty specialist. The head and neck specialists would do the head and neck work. The cardiorespiratory radiology consultants would do sort of chest biopsies, etc. But at DGHs, you could be asked to do a variety of things. You could have on your ultrasound list anything from liver biopsies to lymph node biopsies in head and neck or in the groin or axilla. The other aspects for, I guess, would be like I showed you, X-ray guided or fluoroscopy for stone retrieval in the salivary glands. Yeah, it will depend, and I think it won't be as I guess it won't be as broad as sort of like an interventional radiologist, where you could be putting in stents in ambulatories or nephrostomies to biopsies, but it very much depends. My neuroradiology colleagues tend not to do any procedures at all. Those will be practically 100% diagnostic work. It's very subspecialty dependent.
Okay, that's brilliant. Thank you very much for your talk this morning. It's been really interesting. And thank you for telling us about what life is like in a day of the radiologist. So now I'd like to pass over to Hina and our team of speakers to introduce some of the subspecialties for you.
Yep, so next up we have Dr. Michelle Su, who's just recently become a consultant in breast radiology. So Michelle, you should be able to share your screen to share your slides.
Hi, can you hear me?
Yep, we can hear you.
Okay. Are you seeing the full screen of my presentation?
No, we can just see a blank screen at the moment.
Oh, okay. What about now?
It's still a blank screen.
I can see your screen, Michelle.
Ooh. Can everyone else see it?
If you just go full screen on your presentation, we should be able to see it now.
Okay, is that?
There we go. Yeah, that's
okay.
it.
Okay, thanks. Yeah, so my name's Michelle, and I've recently completed my specialty training in breast and oncology radiology. And I'm just going to be talking about what my specialty, which is breast, and why I think it's one of the best specialties and you should consider it. So broadly speaking, what does a breast radiologist do? So there are basically two groups of patients that we work with. So there's symptomatic patients, and then there's patients from the breast screening program. So the symptomatic patients would be the ones that present to their GP with a lump, for example, and then they get referred to us via the 2-week wait pathway. It also includes patients that may have an incidental finding of a breast lesion on a CT scan, for example, and then they also come through us via the 2-week wait clinic. The screening patients are the ones that attend the breast screening program. So they would be females aged 50 to 71 who come for a mammogram every 3 years. And we would review their mammograms, and if there is any abnormality that we see, we then call them and they come to our dedicated screening assessment clinic. With both these groups of patients, we not only do the diagnostic work, so all the imaging such as ultrasound, mammograms, MRIs, but we also do any of the interventions that are image guided. So if we see something on ultrasound or a mammogram, then we would either take a core biopsy of it, or we may aspirate it. And also some of these lesions, after they've had the initial core biopsy, they may need to be completely excised. And with the technology that we have nowadays, we can actually do that using imaging. So previously, the patient may have to go and see a surgeon and be a day case or take up a bed, whereas now we can actually do it ourselves, and it only takes 20 minutes. and we monitor the patient for maybe an hour afterwards, and then they can be discharged home. So we are not only a big role to play in terms of diagnosis, but we also do play a part in the treatment and management of the patients as well. So what does a day-to-day work look like in breast radiology? So for me, on my Mondays, I do a symptomatic clinic in the morning, and then in the afternoon, I would either report MRI studies, or there is a relatively new technique now, which is called CESM, which is contrast enhanced spectral mammography. And that's basically performing a mammogram, but then also injecting contrast into the patient so that any lesions enhance on the mammogram. So it makes it a lot more sensitive to lesions that might be masked by very dense breasts. On a Tuesday, we also have what's called a follow-up clinic. So these might be patients that have already been seen, but they've been discussed at MDT, and actually there's a bit more further work that needs to be done. For example, there might be a second lesion that actually wasn't seen before they had the MRI, for example, and then the MRI has shown a second lesion, and they might need a biopsy of a second lesion. Or it could be a patient is going for surgery and they need the radiologist to put in a marker or a wire to just localize the lesion so that the surgeon can plan the operation. So for example, in this picture here, labeled B, this is an example of a wire that we would put into a lesion. And the wire tip will be outside the patient, and so then the surgeon can just know in what approach to do the operation. I also do stereotactic procedures in the afternoon. So stereotactic meaning mammogram guided. So sometimes if a patient presents with a lump, we might not see anything on ultrasound, but we can see it on the mammogram. And so then we use the mammogram machine to help guide us with taking the samples. And that's a picture of a stereotactic vacuum biopsy happening at the top right. I also, in addition to breast radiology, do some oncology reporting. So Wednesday is my day away from the breast unit, and I do oncology reporting, so CT scans, MRI scans, and I also do the myeloma MDT. And it's a nice break away from the breast department, and it means it also gives me the opportunity to not be de-skilled in other areas of radiology. So oncology is very general, so I'm still looking at all the different systems of the bodies. I'm not just focused on breast, so I do enjoy my oncology reporting. Thursday is breast MDT, so it's a lot of patients to be discussed. So it does take all morning to prepare for the MDT, and then the MDT itself can last around 2.5 hours. And then in the afternoon, after that, after a very long MDT, it's nice to just do some screen reading. So that's reading the mammograms from the breast screening program, which is a nice end to the Thursday. And then Friday is my assessment clinic. So these are the patients that we've recalled from the breast screening program who happen to have abnormal mammograms. So these patients come to our assessment clinic, and then we do a clinical examination of their breast, and then also do an ultrasound scan. And if there's anything that we need to biopsy or sample, we do it there and then they go and see a breast care nurse to have more of a discussion. And then currently Friday afternoon is just my study session as well. So I think it's a nice balanced timetable. There's plenty of patient contact, and there's plenty of procedures that need to be done, but then there's also moments where I can just sit and report, and it's a bit more chilled out. So how did I get into breast radiology? So I graduated medical school in 2014. I did 2 years of my foundation training in Surrey, and in my F1 year, I was really lucky to have a placement in radiology. in St. Peter's Hospital in Surrey, and there was a breast radiologist there who let me go to his breast clinics, and that was where I became exposed to breast imaging. And I really liked how it was hands-on, and you could do the biopsies, and it was quite satisfying. So that was what put me on a path to doing breast radiology. So in 2016, I applied for radiology training, and then I got accepted into the East Midlands South Deanery. So I did my 3 years of core radiology training, and then after that I did my 2 years of subspecialty training, which was in breast and oncology. And like I said, I chose oncology because it was quite general, multi-systems, and I didn't want to lose my general radiology skills, and I thought oncology was a good extra subspecialty to add on to breast. And then I CCT'd this month as well. So what do I enjoy the most about breast radiology? So I like that the fact that it has patient contact. So it might not be for everyone, but I find it nice to be able to speak to patients, and it means that every day is different, and every case is different. It's very hands-on. We do a lot of procedures, but it's relatively low risk. So it's not like doing an EVAR if you're a vascular radiologist, or putting in a biliary drain if you're a GI intervention radiologist. The worst thing that can really happen is perhaps a pneumothorax or bleeding. But it tends to be very low risk because there's not much really in the breast, and it's very rewarding, especially when it's you have anxious patients that come to you in the 2-week wait clinic, and they've been worrying about this lump for a long time, and they finally summon up the courage to come and see someone about it, and then it actually just turns out to be a cyst, for example, and then you can just put a needle in, drain off the fluid, and then you can watch it disappear on your screen in real time. You could even just turn the screen towards the patient so that they can see it, and then they can see that it's disappearing before their eyes, and it's just really satisfying to see, and the patient is really, really happy about it. And even in cases where it's not a cyst and it's a malignancy, you're there at one of probably the hardest times of that patient's life, but you know that you are doing the right thing for them, and they are also very grateful that you found a problem and you're doing something about it. It is challenging in that some cases can be quite complicated. There can be many things going on. There might be that you can have cases where there might be 3 or 4 lesions in the patient, 2 on each side, and it's just working out which lesion is what. So it's some patients are a little bit more complex than others, but that keeps things interesting. And there is variety. I know it's just the breast that we are looking at, but because of the varied patients that we see, and also there's different kind of pathologies that we see. There's the benign stuff, there's the malignant stuff, but then there's also these things that we call B3 lesions, which are sort of indeterminate lesions that may have a risk of associated cancers developing later on, and they have their own kind of pathways of managing them. So there is a lot of pathology actually in breast, which I don't think you really appreciate until you do the specialty. And it involves a lot of team working. So I'm very lucky in our breast department. We have a really nice team there. The consultants are really nice and supportive. The breast surgeons are very good, and they're also very supportive as well. We have we work very closely with the radiographers. Some of them are consultant radiographers, so they are very experienced, and are they are who I go for advice if I'm doing a mammogram stereotactic guided procedure, because they are the most experienced in that. and we also have RDAs that, you know, help with the patient, getting them more relaxed and, you know, talking to the patient whilst I'm doing a biopsy. So it involves a lot of teamwork, and I enjoy that aspect of it. What do I dislike about breast radiology? It is quite tiring, especially when you're doing clinic. Sometimes the clinic, you start at 9 and it doesn't finish till 1, and it's constant. So, you know, patient after patient after patient, and it's physically tiring because you're always standing, and when you're doing the biopsies, it can be quite tough to like penetrate the tissue, and does require some force sometimes. And also it's just tiring having to talk to patients constantly, explaining your findings, reassuring them, etc. So yeah, I find doing clinics quite tiring, but that's why I don't have clinics back to back. So if it's a morning clinic, I won't have an afternoon clinic, because that would be really tiring. It's known as to be quite a litigious specialty, with sort of a threat of being sued, for example. But to combat that, we do a lot of double reading now. So for the breast screening program, all the mammograms are read by 2 people, and if there is agreement that the mammogram is normal, then that's fine, we say it's normal. If there is any kind of disagreement, it goes to a 3rd person, and then they sort of have the overall opinion. So there is, and also for things like MRI breast studies, they are also double reported as well. And every case where you've done a biopsy, that has to go through the MDT, even if it's a benign thing, it still goes through the MDT. So the MDT person goes through all the images as well. So everything kind of gets double checked, which you can look at it in both a positive or negative way. I see it as a positive thing. So I think that, you know, there's less chance of me missing something because it's always being double checked. But for some people, they might not like the fact that, you know, their work is not very independent and they're always being monitored, for example. But I see it as more of a good safety net. Doing clinics and obviously having patient contact and doing the procedures means that we don't really have the opportunity to do home working, which for me is not so much a problem because I really enjoy my work. But if you are looking to perhaps be mainly a home reporter, then breast might not be the one for you. But there are moves to make reading the mammograms paperless, so that potentially you could have, you know, a half day working from home reading the mammograms, for example. And also breast units, in my experience, tend to be quite isolated from the main imaging department. It's always sort of somewhere separate in a separate building, and you don't really get to interact much with other radiologists from other interests. So it can be quite isolating, can feel quite separated from the others. But that's why I also have my hand in oncology, so I still get to see other people not doing breast. So what are my advice for the next generation? So I think if you're really interested in radiology, definitely do either some student placements like your SSCs, and also arrange to do taster weeks in your F1, F2 years. And then you can, yeah, if you are interested in breast, I would speak to the person arranging your taster week, whether you can have a session in the breast department, and then you can really get to see what we do, because it is very different to all the other specialties. And then you can also use that time to talk to the trainees as well. I would also definitely try to initiate a radiology themed audit and try and complete the cycle and then present it at a radiology meeting nationally, like the BIR, for example. and that will be really good for your CV, but you also learn by doing the audit as well. But more of a general tip is just to work out what you really value most in your career. So do you want to be happy, or do you want to make lots of money, or do you want to have a good reputation and be quite well thought of by your colleagues, for example? They do say the stereotype is that if you want to be happy, you become a breast radiologist. If you want to make money, you do MSK Radiology. And if you want to be famous, you do IR. So I'm very much happy with being happy. So and I am happy doing breast radiology. So it's just working out what makes you tick, and then you can kind of work out what would be the best route for you. Thank you.
Thanks, Michelle. That was a great talk on breast radiology. Next up, as we have no questions at the moment, we have Sanjeev, Dr. Sanjeev Ramachandran, who's one of our ST4 colleagues specialising in molecular and oncology imaging.
Hi, Ina, can you hear me?
Yes.
Brilliant. So I'm just going to share my screen. Great. Can you see my screen now?
Yep.
Lovely. So hi, everyone. So as Hina said, my name's Sanjeev. I'm currently an ST4 Radiology Reg working in Leicester. So I'm going to give you a talk on academic radiology, so something slightly different to what Michelle and Vincent have spoken about just now. So I'll give you a bit of background about my career thus far. So I graduated from Imperial in 2016 and then did a academic foundation program in Cambridge for F1 and F2. And then I applied for the academic clinical fellowship in radiology starting from 2018. I've literally just finished it a few months ago. So I think I've had enough of a taster of sort of the academic side of things to just discuss with you guys, if you are considering going down sort of the research or teaching side of things, what the process might be and sort of the pros and cons that would come with it. So I'm assuming there'll be a mixture of you guys. So some of you will be final years and some of you will be sort of more halfway through med school, but you may or may not have come across this diagram, which is the sort of the formal NIHR academic training pathway, which is set up so that trainees now have a very sort of well-formulated structure if they are interested in combining a research or educational career with their clinical training. There's a set pathway for them to follow. So hope you can see my arrow, but right on the left-hand side is where you guys will be now. So that's medical school. And within medical school, there are plenty of options to get involved in research. So you can pursue an integrated BSc. Some people do a PhD as part of it. But there's obviously lots of projects and stuff that you can involve, which is probably what most people sort of get their first taste of research from. So you can do sort of select modules and also just approach supervisors to get involved in research. And I think that's probably at that early stage, a lot of people do get the research bug and say, okay, actually, I really like doing these projects. And you might start considering going further along this pathway at that stage. Alternatively, there'll be lots who probably do that and say, it's not really for me. And that's absolutely fine, because throughout your career, you might sort of change your mind on how much research you actually want to get involved in. But this pathway will always be open for you if you do decide to change your mind later on. So at the end of medical school, in your final year, you have the option of applying for something called the AFP, or Academic Foundation Program, where usually they offer you, out of the 2 years, 4 months of protected research time, where you can pursue a number of different projects, mainly in research, but there are some posts, for example, in leadership and management and teaching and education. And during your F2 year, or if you decide to take an F3, etc., around the beginning of the academic year, you do get the opportunity to apply for this thing called the Academic Clinical Fellowship, or ACF, which is a 3-year training program. I'll just go through in my next slide, I think. But that usually lasts during your early registrar years over here. And after that, the point of it is to sort of see if you're interested in pursuing a PhD. And once you get that qualification of a PhD and you get that extra research experience, you start hitting these higher end sort of posts. So academic clinical lecturer is something you do towards the end of your training, where you spend sort of at least 50% of your time doing research. And that takes you up to your CCT, where when you apply for a consultant, you can also go for sort of formal academic posts such as lecturers or professors. So specifically talking about my radiology experience, so I applied for an ACF in my F2, which was a different application process. So I had to apply for both clinical radiology through the normal national process, but I also had to do a separate application, which involved a lot of sort of white space questions and a separate interview process as well. So it was 3 years in total. So for me personally, it was between 2018 and 2021. And if you remember me mentioning, so in the AFP, you had 4 months of protected research time. So the further you go along your academic career, they actually try and give you more time. So for me, or for most ACFs, they now give you 9 months time, but it's spread out over 3 years. So you spend roughly 25% of your time doing research. And the main aim of the ACF that I've mentioned before is to support you for a PhD funding application. However, this is not compulsory. A lot of people do ACFs just sort of get a bit more experience with kind of research, get involved in projects, and it gives you sort of a little bit of a bigger skill set. The other advantage of an ACF is you do get a formal qualification out of it now in most deaneries. So you get a master's degree. Even if you apply for a PhD and you don't get one, you still have something to show at the end of the program. So application process. So I think for you guys, obviously ACF's a little bit further down the line, but I'll just talk a little bit about the application process for AFPs. I ignore the top bit because that mainly applies for ACS, but for AFPs, I think the main thing you have to realize is that you do probably need to be a little bit ahead of the game in knowing what the process involves, because there's a bit more work that involves on top of your normal F1 application process. So the F1 process, obviously you need to pass your med school exams, you need to worry about your SJT, those kind of things. But for academic applications, whether they're AFP or ACS, you do have to do an extra application form, and they usually have these sort of white space questions. So the things I put in brackets are sort of roughly what they might be looking for, but it really depends on which deanery you apply. So when I was applying for my AFPs, we were allowed to apply for 2 deaneries. I'm not sure whether that's changed now, but I think once you've picked them, it's they do tell you quite clearly exactly what they're looking for. So I, for example, applied for Wales and Cambridge, and both of them had 3 white space questions on the application form, talking about things like, when have you done research? What have you learned from it? Tell me about a time you've had some teaching experience, for example. So it's these little things that you can sort of start preparing in your med school years. It's looking ahead to try and have something to write on there would be very helpful if you're interested in pursuing academia. And then I think the main difference is the fact that if you are applying for these academic posts, and AFPs in particular, you do have to go through an interview process. When you're applying for the standard F1, I think it's just mainly done on SJT and your decile, whereas here they actually do want to see you. It was in person, but probably going to be remote now these days. But regardless, they will have like sort of a clinical interview where they ask you to talk through a clinical scenario. So for example, I got an interview question on how to manage anaphylaxis, and had to talk about sort of the medical aspects of it and other sort of non-clinical aspects surrounding that. And an academic interview where sometimes they'll give you sort of a paper or some data to sort of interpret, and they'll ask you lots of questions about your research experience and what you actually want to get out of your AFP or ACF. And then, yeah, so you do need to be benchmarked. So obviously you need to sort of pass your medical school finals and do your SJT as well. So you can't, unfortunately, you can't get out of doing an SJT because the AFP and the normal foundation program do run side by side. So what do I like about sort of a time in academic career? So what I think I appreciated the most is that you actually have time out of your training just to do research, which is really nice because a lot of the time, what you've had to do, for example, in med school and even when you're working as a doctor, is sort of you're doing lectures, you're studying, and then just going in on weekends or your evenings is trying to help out with these different projects or writing up some kind of paper, and it can sort of eat into your free time. So the fact that you do have this time to kind of pursue your own interest in a project is quite nice. If you're interested in sort of going to that higher end of your career with academia, so if your dream was to become a professor or to get a PhD, this protected time, especially within an ACF, is really excellent because you get good contact and formal contact with a lot of professors and supervisors who are there literally to say, look, we are here for you. We've taken you on this job because we think that we can help you, which is a really nice feeling because you have that option open for you. And if you're interested in getting your research out there and you get a buzz out of publishing or presenting at international, national conferences, there's a lot more opportunities that's available in these AFPs and ACFs. Like I mentioned before, you can get additional qualifications. So I know some colleagues, even in AFPs, who've got sort of PG certs and stuff out of it because they've got that protected time to actually do it, and they've got the opportunity given to them. So it's all funded by their respective deanery. And even at the end of it, even if you do all this and you say, actually, you know what, I don't want to be a professor, I just want to be, you know, a normal radiologist or a normal clinician who just wants to do my job, I don't really want to get into research as much, it's still useful because it improves your generic skills. As a doctor, sort of you're doing your day-to-day work, but it's good to just have your eye on research, and knowing how to read papers and knowing how research is done does improve, I think, how you practice. There are some downsides to academia, as there is with everything. So I think one of the biggest challenges I had, especially in my ACF, was that because I had to give up 25% of my time over 3 years to do research, that means I had to squeeze the rest of my work, clinical radiology work, into 75% time. So I had to keep a little bit on top of the game and be a bit more organized to try and make sure I still am hitting what I need to with my radiology skills. With AFP, I found that it was a little less challenging because you do have to still get your full competencies, but the requirements were a little less difficult to get because it's mainly based on workplace-based assessments like mini KEXs and CBDs and stuff. You do still need to be organized because in your F2, if you're doing a 4-month block, for example, the mini KEXs and CBDs that you need to get in that block, you just have to bear in mind that, okay, actually, I don't have a whole year like the rest of the trainees do. I need to squeeze it into 8 months. So it's kind of just, again, a little bit more organized and just remembering that, okay, I need to do this a bit quicker. So just taking the initiative to say, actually, can I get an extra CBD for this rotation or an extra mini KEX, for example? The other disadvantage is that you often have competing priorities. So I was a little bit torn between sort of what I had to do for my research projects and what I had to do for my clinical projects. So for example, in my second year, I had a research MRI list as part of my research project, which I had to attend to, but they were pretty unpredictable. So they might, for example, land on a Tuesday morning, but I'll only find that out at the beginning of the week. And then I had to suddenly tell my clinical supervisor saying, oh, I can't come to my radiology list on a Tuesday morning because I have to go to this research MRI list. And sometimes they didn't quite understand, or they said, okay, how are you going to make up for that time on your list, etc. And I had to sort of negotiate how I can do both things at the same time. Sometimes it's difficult to secure academic time. So in AFPs, they're usually pretty good because it's a bit more streamlined. But the higher up you go, the sort of fewer posts there are. So the understanding amongst the department that, you know, you're actually an academic trainer, you're not just a clinical trainee, sometimes isn't as much as you would want. So you kind of had to negotiate saying, actually, I want a 3-month block. And then you'll sort of have some pressure saying, okay, so how are you going to, if you're taking 3 months out of doing a rotation, say, neuroradiology, how are you going to find the time to then actually learn that if you're doing research? And coming up with a plan with your supervisors to say, how can I balance both at the same time? So that can be a bit challenging as well. So even though I mentioned that you do have protected time, at the end of it, because how research works, you are probably likely to do more work in your free time as well anyway, because things may not go according to plan, or there's always extra work that sort of falls on your lap. And I found that a few of my evenings and weekends, I did have to actually do a little bit of extra work to catch up, especially given the fact that I had to balance my clinical commitments as well. And finally, this is more relevant for ACF, so probably a bit further down the line for you guys, but with ACS, when you're doing your PhD applications, it does require a lot of time and commitment because it's quite a complicated process. Apologies, the rest of my slides blocked off by the logo. But what I wanted to say was, overall, even with these extra challenges on your time, if you find a research project or a topic that you're passionate about, I do think it's ultimately worth it. But that's a decision that you guys will have to make individually as your careers progress. But there's definitely no right or wrong answer with whatever you decide to do. And I think that's my last slide. Thank you very much for your time. Do you have any questions, Hina?
Thanks, Sanjeev. There's no questions for you at the moment, so thank you very much for talking about academic radiology.
Thank you very much.
Next up, we have Dr. Hamza El Ghani. He's one of our IR trainees. So Hamza, when you're ready, please take the floor.
Thanks, Hina. Can you hear me?
Yes.
Okay, great. Thanks. Just trying to share my screen. Can I share my desktop or no?
Yes, you should be able to. If you press share content just at the bottom right.
Yeah.
That should be able to let you share it.
Okay. Yeah. Are you able to see that now?
So I can't see it, but I'm just going to check with George because I've had
Yes, yeah, we can. Thank
Yep.
you.
Okay.
Okay, thanks, Hina. Thanks, George.
Right.
Okay, I'm Hamza, one of the final year trainees. I'm an ST6 at the moment, doing IR in Leicester. Almost 2 months away from CCTing. Next, you can either go straight for a consultant job, or you can go for a post-CCT fellowship in IR, doing some subspecialist work in a subspecialist center, or you can go for research even. For me, I've decided to go for a post-CCT fellowship in Queen Elizabeth, Birmingham, undergo some more detailed or more aggressive interventional oncology work, and get hands-on on endo AVF dialysis fistula creation. So you can create endovascular fistulas using catheters, not the usual surgical way. They go both hand in hand, by the way. We're not replacing surgeons. So just a bit of history about IR. It's been more than a half century of innovation, really. X-ray started in 1895, and this is the X-ray of Mrs. Rontgen. You can see the wedding ring there. Nobel Prize for that. Then in 1927, the first angiogram was performed. Then that was peripheral angiogram. Then in 1929, the first aortogram was performed. The specialty of interventional radiology evolved as an outgrowth of diagnostic catheter angiography. Remember, in the 50s, there were no cross-sectional imaging. We only had plain films and fluoroscopy. The Swedish radiologist Sven Iver-Seldinger, who coined the Seldinger technique, which is simply getting a needle into a vein or an artery, then introducing a wire through a needle, remove the needle, then put a catheter or a sheath on top and do your angiogram. This then became a safe and replicable technique. The radiologists were tempted to treat, were tempted to treat? They were tempted to treat narrowings or blockages. So this is a request for angiography, but it says visualize, but do not try to fix. This was how it was in the 50s. So selective angiography, how do we do it? You go through the groin into the femoral vein, then up anywhere in the body. You can go into the bowel, you can go into the liver, you can go into the spine, you can go into the brain, inject some dye material, the contrast material, take some images, and through these images, it was the method of diagnosing pathologies. For example, there was no cross-sectional imaging to diagnose neuropathologies, so they used to diagnose like meningiomas or other tumors, brain tumors, through angiography. This is how primitive it was back in the day. Even when a patient presented with a bleed or either upper or lower GI, they would go in with a catheter selectively into the mesenteric vessels, all of them celiac, SMA, IMA, interrogate all three and see where the bleeding is coming from prior to laparotomy. So it was just a matter of time before radiologists would take matters into their own hand and starting treatment. And the first person who attempted that was the father of interventional radiology, Dr. Charles Dotter, in 1964. He did the first percutaneous transluminal angioplasty. How did he do it? He was doing a leg angiogram. There was a narrowing, so simply he took a dilator and across the lesion, then another bigger dilator, so serial dilatation, and he managed to break the calcium or the plaque and improve the flow. And this is how it all began. This is Mr. Dotter. So the term of IR was coined in 1967, embolization of the first spinal AVM in 66. Radiologists started percutaneous coronary interventions back in 67, then later on cardiologists took this over, but it's still 50-50 job in some countries like in France. First GI bleed attempt to treat that was done in 67. Coils were introduced in 1970s. First trauma embolization in 73. First thrombolysis for arterial occlusion in 74. First chemoembolization for a liver tumor in 77. Then first cryoablation that's using ice to kill a tumor percutaneously was done in 1980. TIPS procedure, creating a shunt between the portal circulation and the systemic circulation to reduce the pressure, portal pressure, in cirrhotic or advanced liver disease patients who present with either bleeding or refractory ascites, was introduced in 82. The first ever catheter delivered stent, not a surgical open delivered stent, was done in 1985. First radiofrequency ablation, as in percutaneous radiofrequency ablation for a liver tumor, was done in 1990. Then the first EVAR, that's endovascular repair of abdominal aortic aneurysm, was done in 91. First islet cell transplantation for diabetics in 99. First selective internal radiation, that's the radioembolization equivalent for chemoembolization for liver tumors, was done in 2004. And the youngest procedure we're now adopting is the prostatic artery embolization for benign prostatic hyperplasia, not for malignancies, was introduced in 2009. So you can see here a really wide range of innovation and procedures that have been introduced over the last half centuries, and more to come. There are lots more procedures we do. So what's interventional radiology? It's at the moment, it is a subspecialty of radiology. This is not the case in the States. However, hopefully soon when the UK will get the specialty status, not the current subspecialty status, we use imaging guidance to perform minimally invasive procedures, either under fluoroscopy, that's X-ray, or CT, ultrasound, or MRI guidance. It's really keyhole surgery or pinhole surgery. Our BSIR logo, that's the British Society of Interventional Radiology, has image-guided surgery on it. So some of us really call themselves endovascular surgeons. So what what's special about IR? IR is quicker than open surgery. IR is done under LA, therefore shorter recovery time, and you're able to do procedure in sicker patients who would not tolerate general anesthesia or even regional ones. IR has its own specialties. There are at least 9 specialties in IR. First, let's start with is vascular IR, treating peripheral legs and aortas. There is non-vascular IR. There is interventional oncology. There's neurointervention radiology, pediatric intervention radiology, lymphatic interventions. That's the world of its own. There's MSK interventions done by our MSK colleagues. Pain management, some radiologists just deal with pain. This is a common territory between us and anesthetists, but we do it image guided, and many, many more. Let's start with vascular IR. We treat peripheral vascular disease, atherosclerotic narrowings or occlusions. Dialysis fistulas, we manage them either, we manage the pre-existing surgically made fistulas, as in treating narrowings in those fistulas, acute blockages or long-standing blockages, angioplasting them, stretching them open with a balloon, or stenting them. We also can create a fistula with a catheter down the artery, then a catheter down the vein in the arm, then we use an radio frequency wave, create a channel between both, then pull everything out. It's cosmetically and physiologically better for the patient. As it stands, it's very new, it's been around for 7-8 years. Evidence is still growing. There is growing acceptance. We're doing it like as one of the possible options for access for these patients. Treatment of aortic disease, namely aneurysmal disease, either in an emergency or elective settings, either abdominal or thoracic. We also treat venous disease, as in DVT, iliofemoral DVT, that's suprainguinal DVT. Infrainguinal DVT is for medical treatment. Suprainguinal DVT is for interventional radiology to deal with. We either go in an acute setting and do a mechanical thrombectomy, or after it becomes organized and becomes what we call chronic DVT. Some people don't like this term, but if it's chronic, we can go in and recanalize the whole thing, iliac veins, IVC, and stent it, and improve the quality of life of the patient and post-thrombotic syndromes. IVC filters to protect against PE in chemotherapy patients or patients who can't have anticoagulations for some reason. PE, we do have a role in management of pulmonary embolism as well. And certain subset of patients with hemodynamically unstable patients where the PE is massive and blocking both arteries, we go in with special devices and suck them out, and the patient OBS and saturations improve on table within 10 minutes as well. Dealing with active hemoptysis, either post-infective or post-irradiation, we go in and block off the bronchial artery that supplies this bleeder. Management of uterine fibroids, it's been around for almost 30 years. It has comparable results to myomectomy. It's a world of its own. And recently treating prostatic BPHs, benign prostatic hyperplasia, in patients who are not fit for surgery or who opt to have a prostatic artery embolization instead of the normal TURPT or laser or whatever treatment option is given. There's loads of growing evidence, and I believe shortly it will become equal to surgery. Treatment of these patients are best medical treatment to start with. If they don't respond, we need to go to either prostatic artery embolization or surgery. Varicoceles and ovarian syndromes, where you have ovarian tortuous ovarian veins in the pelvis, we go in and treat them and coil both of them. We also deal with the acute side of things, as an emergency embolization for bleeders, for trauma. We either put some coils, whatever embolic agent we've got, or stent it. And we've discussed TIPS as well. TIPS can be done as an emergency procedure, like the case I did on Friday, where there's an alcoholic liver disease patient. She's presenting with massive varices in the duodenum, and endoscopy couldn't control it. So we went in and did an emergency TIPS to reduce the pressure and divert the blood away from the varices, and it worked well for the patient. Or we can do it as an elective procedure for refractory ascites or so. This is an example of peripheral vascular disease. That's an SFA, superficial femoral artery in the leg. It's blocked. Then we go subintimal approach. You can see the wire in the middle picture. Then we recanalize and open the whole thing. Then you can see the continuity of the lumen and the contrast opacifying nicely the vessel. That's the principle of EVAR, that's abdominal aortic aneurysm repair, where we exclude the aneurysm lumen by putting a bifurcated stent across the aneurysm and treating those subset of patients. That's an example of fistuloplasty, dialysis fistula in the arm, treating it, stretching it with a balloon. You can see the narrowings here. Then you're trying to crack this narrowing with a balloon. You can see the wasting, then treatment is nice and open. Iliac DVT, that's a chronic one. That's a femoral vein access. Inject contrast here, nothing is going north. These are all collaterals. We cross it with a wire, do a mechanical thrombectomy, thrombolysis maybe sometimes, take the clot out, then stent the whole thing. You can see the restoration of the lumen nice and good. And those subset of patients are really grateful because they experience immediate relief, immediate as within a day, relief of the leg swelling and all the compressive symptoms they've got. GI bleeds, that's one of the scope of the emergency or acute IR. There's a pseudoaneurysm here on the on the fluoroscopy. You do an angiogram, then you coil embolize it, and there's no more bleeding. That was some of the things we do in vascular IR. What about non-vascular IR? There's the standard biopsy and drainage, and this is a core skill that anybody should learn during the first 3 years and be really good at. Nephrostomy insertions for blocked urinary systems or JJ stenting. We do antegrade JJ stenting, by the way, from the top. Urologists do it from the bottom through a cystoscope. We can do deal with blocked biliary systems. We go through the skin doing a percutaneous biliary drainage, plus or minus stenting if needed, either for cancer or for benign disease as strictures and so leakage. We also contribute to gastrointestinal stenting, either esophageal, gastric outlet obstructions, or even colonic obstructions for malignancies. We can do percutaneous gastrostomies if the endoscopic approach fails or is not feasible. We can do jejunostomies or even cecostomies through the cecum. So that's a CT axial image of an abscess, subcapsular abscess, going with a needle on the CT guidance that leave your drain behind. That's a lung nodule. You go through percutaneously, hit the nodule, take a sample, and pull out. That's a hydronephrotic kidney. You go in with a needle under ultrasound guidance, take your wire down and your tube, and bang, you've got your nice pigtail loop there, and you're draining the kidney, the obstructed system. Biliary drainage, you go in percutaneously, inject some contrast. That's the left hepatic lobe, right hepatic lobe, and that's a CBD. No contrast is going through. Then you manage to cross it with your catheter. Then you leave a tube behind, or you can stent it. That's like an apple core cancer-like appearance of a classical esophageal cancer. That's a barium swallow, and that's post-stenting. The stent has an anti-reflux mechanism to stop aspiration. That's only a very small scope of the non-vascular intervention. Third, interventional oncology. It's an ever-expanding new world, doing chemoembolization, treating primarily HCC lesions or metastatic colorectal cancer, neuroendocrine malignancies. You can do the same technique, but using internal radiation, using yttrium-90, ablations, percutaneous ablations under heavy sedation or GA. You can do radiofrequency, burn the tumor out using radiofrequency wave, microwaves. That's heating part. You can kill it with ice, with cryoablation, or the new baby, that's the IRE. It's still experimental. That's an HCC there. Then you inject the chemoembolizing material, lipidol. You cover the whole lesion. Then over time, it shrinks down, and here you treat the lesion, the HCC lesion. Then you can do percutaneous ablation, where you have a needle connected to the RF device, for example, and under ultrasound guidance, you take it into the lesion and burn it out with a safety margin. Ablations are equivalent to resections, so they are curable for these patients if they fit the criteria. Neurointervention, it's a world of its own. You do it as a specialty training. You go in from year 4 to year 6 in a neuroscience center. You spend your time only treating neuro patients. What kind of patients do you treat? Patients with stroke. You do mechanical thrombectomies for large vessel occlusions. You can do aneurysm coiling, either in the setting of an acute subarachnoid hemorrhage or an elective setting to stop possible bleeding. You can do arteriovenous malformation embolizations electively or acutely as well, carotid artery stenting, carotid bulb and ICA stenosis. Results are comparable to endarterectomy for those subset of patients or with high risk of TIAs, venous stenting for any cause of venous hypertension or IIH, as well in the brain, treating AV fistulas in the dura, either in the skull, in the brain, or in the spine. So they've got really good results and the world of their own. You can see on the left here, image A, dense, what we call a dense right MCA sign. Go in with a catheter, inject contrast. The contrast column stops here. You go in with special device, retrieve the clot, the filling defect here, then you inject contrast and you've got restoration of flow. You save lives every day. It's not easy, but it's done. There's a learning curve to it as well. That's a narrowed internal carotid artery, pre-stenting and post-stenting. This is done in patients with high risk of TIA or unstable flux. So how do you get into IR training in the UK? In the next recruitment, I believe, and others might talk about that as well, you can go now into IR from 2022, directly into IR from year 1, straight through training. It's run through. First 3 years, you'll do core radiology as your diagnostic colleagues, but you have like more sessions of IR, more hands-on. From day 1, you're flagged as an IR trainee. You'll be looked after and you do more sessions, but you'll need to have your core radiology training and go through the same examination process and the same recruitment process even. And you can swap back to diagnostic radiology if you don't enjoy it back in year 4, or the other way around. You can go into core radiology as a diagnostic trainee from year 1, then go into IR from year 4, do 3 years, then CCT and IR as it's happening now. So it's interchangeable, really. So foundation year 1 or 2, or other specialty, core training, then 4 or 5, 6 IR training for IR trainees. Or you can do IR from day 1 till year 6. So as discussed, after CCT, you can do national or overseas subspecialty fellowships, some of which, especially the Canadian ones, you need to apply 2 years in advance for a fellowship there. You can go research after CCT. You can become a consultant straight away. Lots of research options. There was an ad in New York, for example. There's a fresh one for recently, I think, in California. So we have lots of societies we can affiliate to, namely our British one. That's the British Society of Interventional Radiology, which is the home of image-guided surgery. It's been founded in 1988. They hold multiple meetings, like the annual society meeting, webinars, and the BSIRT, that's the BSIR trainee forum. BSIR is fighting for the specialty status. They're not successful now, but at least they managed to introduce IR training from year 1 starting next year, which is quite a gain. We have our European Society, which is called CIRSI, which stands for Cardiovascular Interventional Radiology Society of Europe. They set standards, guidelines for Europe, and they set curricula as well. As you can see here, there's a curriculum, IR curriculum for medical students, and curriculum for IR training, and for IO. IO stands for Interventional Oncology Training as well. This is the CVIR, is the journal for CIRSI. There is an exam now. It's been around for a few years now. That's the European Board of Interventional Radiology, held by CIRSI twice yearly. So far, there have been 24 examinations and 670 certified IRs. This is not, it's not mandatory in the UK as it stands, but it's gaining more and more an acceptance as a benchmark reflecting your knowledge and level of expertise. Many trainees who qualified in the last, let's say, 4 or 5 years have sat this exam. You don't need to this exam to get an IR job in the UK. But it's getting more acceptance in Europe, and lots of European countries are setting the standard as a must to become a consultant there. CRC holds more than one conference, the annual society meeting, and there's a special conference for annual conference for interventional oncology, IO, and there's a special one for embolotherapy that's just for embolization every year, and there's one for complications that was cancelled during COVID, unfortunately. And there's under CC comes the European School of Interventional Radiology, which holds workshops every year, at least 4 or 5 every year, where you can go and get hands-on on new stuff that you don't get in your normal practice. So you can have an idea what are the updates, how people are doing it. You can bring some expertise back and just get some proctoring and start services in your place. Opportunities for consultant jobs. There's massive demand for IR in the UK, which is not met at the moment. The census, work census force released by the Royal College of Radiologists showed that there were 48 advertised unfilled jobs back in 19. This means that they were available. You can add lots of jobs to this that were advertised before and unfilled, or where you can approach certain hospital and the clinical director of IR and say, I'm willing to come and I'm interested to come and just join your team, and they'll create a job for you. So the job market, there's no concern for IR at the moment. So pre-training resources at your stage, there's the BSIRT, the resources for medical students on CERSI website as well. There's the famous Radiology Cafe, which can help you prepare for your application. And there's the IR Juniors group. There's a channel for that on YouTube, which you can follow, and you can just watch videos on updates and what's going on in intervention. So how is life as an IR? Most of IRs are not competitive, which is really good. We enjoy working together as a team, and we look after each other. It's really kind of an extended family. IR is still evolving. It's very young. It's like a revolution. It's becoming the heartbeat of medicine at the moment, I can say, because whenever any specialty is stuck, like a medic, they call surgery. If surgeons are stuck, call IR, see if they have any answer to this problem. Because there are massive breakthrough over the last years, and we really help other specialties. You can do, as a career as an IR, you can do IR with diagnostic sessions. You can mix especially body reporting, which I'm doing myself. You can do IR full-time without any other diagnostic sessions for any other specialties. You can only report your vascular scans. You can do IR and part research. You can do IR and full-time research, and you can become an academic, like Sanjeev explained, or you can go to the private world, but it's really not that, the private world is not that bright in the UK, maybe in mainland Europe. So IR is for you if you are bright, if you're ambitious, if you're a leader, if you're a teacher, a decision maker, and if you're brave. If you're a doctor who wants really to make a difference in a patient's life, go for it. But in the UK, it's challenging. You go for one more year of training. You have more frequent on-calls than your diagnostic colleague, so you need to accept that. You need really to love what you do, need to care for your patients. However, having said that, you can have the balance that other colleagues might not have. You can have the best of both worlds, doing procedures during one session and sitting in your dark room, relaxed and reporting some scans, which is the best of both worlds, which I like most about IR. So what are the challenges now? Specialty creeping happening everywhere across the world. We can protect our specialty with certification and always new procedures like prostate and genicular artery embolizations and other. We're always pushing for innovation in IR. There are always emerging technologies. We have lots of toys to play with. It's endless, really. If you see how people are just getting hands-on on lots of new stuff everywhere across the world, it's like going to school every day. Having its own stress, yes, dealing with stuff and having responsibility of care of patients, but you do enjoy the adrenaline rush, to be honest. You have to be cool under pressure, deal with emergency situations, get prepared to improvise and innovate safely, and to deal with colleagues from different background, different specialty, and speak their language. So if you're that guy or that girl, please join us, and thank you very much.
Thank you, Hamza, for talking about IR. That was fantastic. We don't have any questions for you, so nothing to ask just yet. And for our final subspecialty talk, we're going to invite Dr. Kethis Parameswaran to talk about MSK Radiology.
Great, thank you. I'm just going to share my screen, so bear with me. Okay, can you see the screen?
Not yet. Okay, I'm going to get George just to double check because I can't see anything, but I think my system's a bit glitchy.
Yes, yeah, I can see it. Sorry.
Fantastic. Okay. Well, very nice to meet you all. A wonderful talk so far. And I hope you have all been inspired by some of these talks, because radiology is one of those career choices that's up and coming. And some of the things that are coming out now will revolutionize how patients are being managed. So I'm Kethis. I'm one of the consultant radiologists. I actually work at Croydon down in South London, but I was a trainee up in Leicester. And I'm going to inspire you about MSK radiology. So that's musculoskeletal radiology, and kind of the things that I do, and hopefully may make you choose radiology as a career. So let's talk through sort of typical week in my practice. So I work at a relatively busy DGH, and fundamentally my job includes diagnostic and interventional work. So from a diagnostic perspective, I do musculoskeletal imaging, both acute musculoskeletal imaging and then cold routine work, which comprises of various imaging modalities. So MRI, CT and X-ray imaging mostly, and then I've also got diagnostic ultrasound imaging. So you can imagine how often you injure your knee or your shoulder, and how frequent it is for a GP to request a scan, and therefore you can imagine the volume of work that essentially comes towards us as MSK radiologists in terms of reporting, not only just doing ultrasounds, but actually reporting sort of MRs and CTs. Whenever you fracture something, you tend to have a plain film. If it's a bit more complex, you end up having a CT, and we're the radiologists that then end up reporting these complex scans. But in addition to all of those diagnostic work, you've also got the interventional aspects, and this is predominantly one of the areas that really interested me. So when I was thinking about radiology, I was very interested, like Hamza, who's previously spoken, in interventional radiology. But one of the things that I didn't like, and this is just me, I like seeing patients that sort of were relatively well, doing a procedure on them and then letting them walk out relatively well, if that makes sense. You're doing something that will make a difference. And you see that response then and there when you do that intervention. And I found that I wasn't quite geared up like Hamza is. We're doing sort of the vascular, seeing all the blood rushing out, and you've really got to be geared to do that. So I thought, okay, maybe I've got to switch my specialty choice slightly, and I found that actually interventional MSK work was definitely my forte. So with the interventional work, you actually do a lot of things. So as Hamza's again alluded to, you do a lot of ultrasound guided intervention. So steroid guided injections, local anesthetic guided injections. You can also do contrast injections as well into all of these joints. You can imagine how many we have throughout our whole body. In addition to that, you've got the potential doing the ultrasound guided biopsies. And then I've also developed a subspecialty in doing CT guided interventional bone biopsies as well. We also do arthrograms to look at, for example, the hips, shoulders, the actual joint itself, and then we view them under MRI, but do the injection under fluoroscopy. So there's all these different modalities that you end up using from an interventional MSK point of view to help with the patient management and treatment. In addition to that, during my week, I also do some cold reporting and some acute reporting, which is general. So that's sort of the malignancy scans. And this is more just to keep my interest in sort of general oncology as well. So I like doing that. And then specifically, again, relating to MSK, there's MDTs, so the orthopedic and rheumatology MDTs, which are quite nice because you get to meet the clinicians. And there's also an on-call commitment, which a few of the other presenters have alluded to. So in addition to all of that, because I had the benefit of working at DGH, I've got flexible home working sessions, so I can do 2 or 3. I've got home working stations, so I can do 2 or 3 sessions at home. You also will have protected time for research and study. And then out of my NHS job, I also do some teleradiology. So if you have any questions, then please put them in the box with regards to teleradiology. So let's talk through a bit of MSK intervention. This is kind of stuff that I do on a day-to-day basis. So here, this image here, we've got a patient that's being injected. Here's the needle coming in. This is the subacromial subdeltoid bursa within the shoulder, and we're popping in some steroid and some anesthetic into the site. And immediately the patient tends to get some sort of relief within sometimes in the next few minutes to a few hours after they've had the injection. Here you've got an example of a patient that's had a CT-guided bone biopsy. Here, this is the left iliac bone. There's a lesion sitting within the left iliac bone, and we've got a needle going straight through. So it could be very precise. We're talking millimeters. If you move millimeters away, up or down, or even to the side, or you angle your needle in any different way, you end up going straight into viscera, this or bowel in this case. You could go into nerves, you could go into the sciatic nerve, for example, you could go into vessels. So you could be very precise with these CT guided bone biopsies. Here we're going straight through a transpedicular approach right into the vertebral body to try and get a biopsy of this lesion within the vertebral body. And so these are the kind of things that I would do. You don't have as frequent cases as you would do in a tertiary center, but enough to keep me entertained on a daily basis. This is an example of a fluoroscopic image. So we've got a needle tracking straight into the right hip joint, and then we inject contrast, and this is contrast in a very degenerated hip. And then when we do an MRI with the contrast that we've just injected, we can then have a look at particular anatomical structures that weren't initially visualized. So things like the labrum, any particular ligaments, any loose bodies within the actual joint itself. So there are benefits of doing things under different modalities. And then finally, one of the things that you don't often see, because they're normally the tertiary centers that tend to deal with these things. So this lesion here is an osteoid osteoma within the bone, and we've got a needle going straight into it. It's actually a radiofrequency ablation needle that's going straight through, burns away the osteoid osteoma, and then this patient is now pain-free. So kind of examples of some of the MSK intervention that we do in addition to the diagnostic work. So my path into MSK radiology, did F1, F2, did a taste a week. So I strongly recommend that. Well, I think now it's crucial that you do a taste a week. And it doesn't have to be within MSK radiology if you have a particular interest there, but do something within radiology to make sure you understand what's happening. I then got the training number in Leicester, so that's the East Midlands Deanery. First 3 years were predominantly the core radiology training that you do. And then the last 2 years, you end up sub-specializing in MSK radiology. And in addition to that, you also do MSK intervention. It's part of the curriculum there. I had the added benefit of Leicester being a soft tissue sarcoma center. So in addition to the general MSK work that we did, I also did soft tissue biopsies, got a feel of the sarcoma MDTs, and some of the soft tissue oncology within MSK that you can deal with. Not quite bone sarcoma as such, wasn't something that I was interested in. So those are specialist centers that are available. And if you want to spend some time at these bone tumor centers, then you can, and the curriculum allows you to do that. So there's always flexibility. If you feel that you haven't fully fulfilled all of the interest that you have within the 2 subspecialist years that you're there, then you can always venture out and go out and even extend your CCT by 6 months just to get the additional field. So there is a beauty with the way that the curriculum is set. And then I thought, okay, I've learned as much as I can within Leicester, but I'm still not quite ready enough to jump to consultant. So I decided to take on a MSK fellowship. So I did this at Imperial College. And here, this was mainly focused on intervention, the benefit of intervention, complex orthopedic, orthoplastic work, and imaging. There was also focus on sports medicine, complex rheumatology work. Imperial is also a major trauma center, so looking at some of the major trauma that comes out, the code red calls, and being able to deal with that. And then, ironically, it's also a quaternary center for myositis. So one of the things they do there is image-guided muscle biopsies, which are actually open, and then looking at the different types of gene inherited myositis. So that was a particular interest that I had when I was doing the fellowship there, and I found that quite valuable because it's something that you will never get the opportunity to do elsewhere, because it all gets sent to Imperial to be reviewed. And then I felt after that 1 year, I'd pretty much learned enough of MSK. I think I was ready to jump ship. So then I took on the consultant MSK radiology job. But I realized throughout these 6 years that I had done the training that I probably didn't want to spend all of my time and my career within a tertiary center. So I wanted to kind of take a step back and focus on family, etc. So I decided I wanted a bit more of a relaxed lifestyle, let's put it that way. And then therefore ended up going and working in a DGH. And there are differences between the two. A few of our presenters already alluded to that. And there are obviously benefits of the two as well. So for me, I wanted a bit more of a relaxed lifestyle. Again, your progression may not be as much as within a tertiary center, but this is what fitted well with me. So I chose MSK mainly because I'm interested in that body mechanics. But two of the big reasons were, one of them was I was inspired by a senior MSK radiology consultant when I was a trainee, really took me on board. And then I realized that actually I didn't fit into any of the other specialties. I liked intervention, but as I mentioned, I didn't like going into hardcore intervention, and I wanted a mix of both diagnostic and interventional work. And so I ended up at the end of those 3 years deciding that MSK radiology was for me, and then subspecializing in MSK. So what do I enjoy the most? I think the biggest things really are playing detective's role, being the first person to notice sort of change before any of the clinical symptoms. I'm a bit of a techie sort of person, so I love playing around with the advanced imaging tools. So in addition to the multiplanar reformat that we already, as radiologists, use, I'm starting to use a lot more of the complex work, MPR, that functionality that we've got. We're also doing a lot of 3D imaging, looking at tiny fragments and where they are to assess the orthopedic clinicians. And then I've got a keen interest in fusion imaging and also something called 0TE imaging, which is basically doing an MRI in pediatric patients, but essentially making the image look exactly like a CT. The benefit of that being that you don't have any radiation by using an MRI when compared to a CT. So especially in pediatric patients, that's amazing if we can get the details. So we're just working with the scanners and the physicists to try and get that imaging up and running. And if we are, then it's going to be quite revolutionary and breakthrough in terms of avoiding radiation completely. So, I mean, it's something to look into if you guys have any interviews coming up, or if you ever do have any interviews, trying to see where radiology is going, because that definitely is one of the questions that they will throw at you. What else do I enjoy? Of course, I love the flexible working. I've got home working sessions. The hub working essentially is within the hospital, but you've got that environment to meet with other colleagues. And then part of the teleradiology work that I do also involves working in different countries. So if I really want to, I could go to Australia for a year, or even 6 months, or even 3 months, do a sabbatical year, or even go there for many years as a sabbatical as such, if the hospital allows, and then do teleradiology whilst also traveling around. And it's not just Australia, you've got the opportunity to go elsewhere. There are many hubs that have been set up, so you don't have to take the workstation with you. So there's huge benefits in particularly, I think this really applies to specialties like MSK, where you've got volume and you've got the diagnostic work and the capabilities of doing that kind of reporting to be able to go to places like these. And then, of course, the interaction with the clinical teams. You always felt as radiology trainees that you didn't have that interaction. Of course, you have the MDTs, you get the opportunity to talk with the rheumatologists, and especially as a consultant, you get to meet them face to face and see them and make changes to patient care. What do I dislike? Well, I think I don't have any specific dislikes. I think there are always cons, unfortunately, with any of the jobs. So I guess one would say that most of your work is sort of classified as behind the scenes if you're doing the diagnostic aspects. If it's interventional, of course, you're patient-facing. You see the patients right in front of you. Unfortunately, phone calls are the burden of your life. You'll always get called to either vet a scan, report a scan, or to review a scan. So that's just something that you've just got to get used to, especially as trainees. Sometimes your work can go underappreciated. And then I guess that this is sort of more future. So obviously AI is coming in. So there is, I mean, it's not as established as as I imagined it to be when I thought it was coming through, but it's definitely coming through. So we've got to think about artificial intelligence and how much of a role it plays. But you've got to bear in mind, no computer, no robot can take over any of your interventional work. So you probably, until you're pretty set if you choose radiology and be a radiologist definitely for your career. I would imagine. But these things can change, so you have to keep up with technology from that point of view. So my tips, really, to summarize, really is to say, it's a competitive specialty. So to get a training number, prepare well. And I guess the key is really to get an exposure, do the taster weeks as an F1, F2 when you get there, and really feel if this is something that you can do for the rest of your life. Don't be put off by the taster sessions, because they're really there just to get a feel. And it doesn't necessarily reflect on the actual day-to-day work, because you're not reporting, you're observing, and that's a very different thing. So really get a feel of it if you can. And then again, people will talk about exams. They are tough, unfortunately, but that doesn't determine whether you're a good radiologist or not. So don't be put off by the exams if anyone tells you that. I think it's just part and parcel of the career choice itself. It's a very rewarding specialty, and I'm sure as... Hello? You guys can still hear me, I hope.
Yes, we can.
Yeah, I'm just to summarize, essentially, I'm sure as the others have alluded to, there is money that can be made if you need it. So, and MSK is one of, as I said, with the volumes that you've got, is one of the biggest specialties. MSK Radiology is one of the big specialties that makes the most money, let's put it that way. So yeah, I would strongly advise you that if you're someone that wants a nice, sort of more relaxed, but the opportunity to be quite flexible with your job plan, have interests, but also make a bit of money on the side, then definitely this is the specialty for you. So with that, thank you. If you have any questions, do fire away. Otherwise, I wish you the best of luck.
Amazing. Thank you very much, Kets. We have no questions for you, but that's a fantastic presentation. And I think, George, is it time for a break before we move on to the final talk?
Yeah, I think if we just take a quick, we'll say 1:45, and then quarter past, sorry, so 11:15, and then we'll start again on our final portfolio building talk.
Brilliant. See you guys at 11:15.
Brilliant. Thank you. Hi, is everyone back?
Yep.
Okay, so shall we get started with our final talk of the day then, which is the how to build a portfolio talk. And I will pass over to Hina and the team.
Yes, fantastic. So for our last talk, Dr. Mahima Ramakrishnan is going to take. So once you're ready, please take the floor, and I'll be supporting this talk with her.
Thank you, Hina. Are you able to hear me?
Yes,
Hello?
it's not very clear.
Just a minute, let me just try the headphones. Are you able to hear me now? Hello?
That's a little better. It's still quite muffled.
How about now?
Yeah, that's better.
Yeah, that's better. Awesome. Hi, I'm Mahima. I'm one of the GPST trainees. Let me just try to share my screen. Are you guys able to see the screen?
Yes, we can. Thank you.
We can. So yeah, I'm a GPST1 trainee currently, but I'm really interested in radiology, and I did apply last year. Went through the interview process, but my portfolio score wasn't great. But it was good experience with the interview and how the whole process works. So I'm applying again this year. So I just give a quick talk on how to apply in radiology, how to build your portfolio. So first, when to apply? You can apply during your foundation year 2 training, or during when you're doing another specialty training as well, be it core medical training, surgical training, or the GP training, any training. The other thing is, even if you're doing a trust-free job or a locum work like an F3 job, you can apply for training still. The application process. So I'm sure many of you all must have heard about ORIAL. So that is the application portal through which most of the training applications are done. So the application is via the ORIAL, and the application form involves something called as a self-assessment. So it's kind of a part of your portfolio. I'll be talking in detail in the upcoming slides. So this is uploaded online, with you need to upload your evidence as well, and it's initially a self-scoring system which will be verified by the panel. And then you have the long listing based on your application and your self-assessment. You'll be long listed and you'll be offered the MSRA to apply for MSRA. So this MSRA is the exam that you give. Once you give the exams, based on your score, you need to score really well for the MSRA for radiology training, and you'll be shortlisted for the interview. Due to COVID, since last year, the interviews are held remotely via MS Teams. Once you complete the interview, you'll be asked to do preferencing, which is again through the ORIAL, and then your results will be published. Again, ORIAL. So like I said, it's a nationwide portal for the applying for most of the specialty trainings. So in the ORIAL, the application form, you have to upload a few of the information. So it starts with your personal information, a bit of your employment history. If you're in training, your training details, and you need to also show evidence of your competencies. So if you're doing a foundation program, you need to do show your F2 competencies. The other way is I'm an international medical graduate, so we have something called as a CREST form, which is a competency. So that needs to be uploaded, and you need to show evidence for that. And also you need to be providing references in while applying when applying. So that'll be at least 3 consultant references, and you'll be doing a self-assessment as well during the application. So talking about the self-assessment, so it looks something like this on your oral. So it has these 5 main components, and you need to score yourself based on each. So just going through a bit about each of these. So the first would be a research into career in radiology or nuclear medicine. So these are scored, this will be getting 2 points, 1 point, and 0. So for 2 points, you need to have kind of at least a week in radiology, at least of 3 days. In addition to that, you need to show some portfolio evidence of radiology commitment. This can be in the form of an audit or QIP, any posters, presentations related to radiology. So if you have any of these, then you'll be getting 2 points for that. But if you just have a taster week without any of the audits, QIPs, then you just get 1 point. Then the next would be exceptional undergraduate training, additional degrees, and postgraduate medical qualifications. So again, this is 210, and you get 2 points if you even just have part A or part 1 of your MRCP or MRCS if you're in if you're in FY1 or in FY2. If you have your full MRCP and if it's within 4 years of qualifying, again you get 2 points. Or if you have a first class integrated BSc or similar prior to starting your medicine, or if you've got 2 or more prizes during your undergraduate studies. So all these, if you have any one of these, you can get 2 points there. You can get 1 point if you have part 1 of your MRCP, but that is within 4 years of qualifying. If you have your full MRCP, MRCS beyond 4 years of qualification, and in your intercalated BSc, if you have 2.1, or if you have received 1 prize in your undergraduate studies. The next important thing would be clinical governance. So this would be an audit QIP. This again, you get 2 points if you have a significant contribution to a postgraduate audit or QIP, which has made significant changes to practice, and you've completed more than 1 project a year, which you have presented in a regional, national, or international meeting. So that will get 2 points. For 1 point, if you have an audit, but you haven't presented in any regional or national meeting, then you get 1 point for that. Then going to teaching, in order to get 2 points in teaching, you need to provide evidence that you have either a postgraduate qualification in teaching, or you made a major contribution to either a regional or national teaching program, including organizing the program, or you're a member or fellow of Academy of Medical Educators or higher education academies. You can get 1 point even if you have just a formal teaching with some feedback. This can be either to health professionals or non-medical audience as well, or if you've even attended a teaching the teachers course or similar generic instruction courses, or you have evidence of major contribution to a local teaching program. Then going into research and academic publications, you get 2 points if you have completed a PhD with original research or 2-year MD with original research, or you're the first author in 2 or more peer-reviewed publications. You get 1 point if you're the first author on 1 peer-reviewed publication or co-author in more than 1 peer-reviewed publication, or you have a radiology or nuclear medicine presentation or poster or at a national or international meeting. So this is where you do the scoring on oral and you upload it when you complete your application forms. And this evidence, you need to upload the evidence as well at a later date. This will be checked by by the panel, which consists of the radiology consultants, and they'll either agree with the score that you've given. If they don't agree, they'll let you know, and you can appeal against that as well if you need to. Then the current 2022 recruitment timeline. So the application period has already started. It was from the 4th of November, and the applications are closing on the 1st of December. Then once you submit your application, you'll be asked to upload your evidence as per the self-assessment that you've done. So This is between the 17th December to 7th of January. You'll be getting the invitations to attend the MSRA exams in the end of December, 21st December, and the exams are conducted between 6th to 15th January. The exams happen at Pearson VUE assessment centers. So it's mainly, you need to go to the centers to have the exams. Then the results will be in the beginning of February. The invitations for the interview will be immediately after you get the MSRA results, around the 7th of February. And like I said, because of COVID, the interviews are held remotely via MS Teams. This will be conducted between 21st to 24th February. And the initial offers, once you completed an interview, will be in the beginning of March, around 14th March. So again, 3 big steps in order to enter radiology training. First would be the MSRA exams. The next is the portfolio, and then the interview. So the exams, it's a multi-specialty recruitment assessment exam. It's for many of the specialties, they undergo these exams. Other than radiology, like ophthalmology, GP training, obs gynae, anesthetics, many of the training programs, this is kind of an initial assessment. So it's a computer-based exam, and it forms your basis for your shortlisting score. It contributes about 1/3 to your overall selection score. And it has 2 parts. One is a professional dilemma questions, and the other would be the clinical problem solving. So each of them are independently timed. The professional dilemma questions, I'm sure you're aware of the situational judgmental questions that you have in medical school. So they're very similar to those. They include like working in a ward, working with a colleague, any ethical issues, patient confidentiality, those kind of questions. And they have 2 types of questions there. One would be the multiple choice questions, and one would be the ranking questions. And then you have the clinical problem solving. They are to test your clinical knowledge. So they include a wide variety of specialties: medicine, obs gynae, pediatrics, dermatology, rheumatology, all of those. There are very useful resources which are available online, question banks. In Pass Medicine, MCQ Bank, eMedica, Pastas, they all have amazing question banks for both the SJTs as well as the clinical questions. Like I said, the exams delivered at the Pearson VUE assessment centers. If you're shielding or isolating, they do offer some different methods to take the exams from home. And like I said, the current timeline, the exams are between 6th to 15th January, and the results will be in the beginning of February. Now going to your portfolio. Initially, before COVID, the portfolio was all paper-based. So you will be, when you go for the interview in person, you'll be showing the evidence on paper. But because of COVID and because the interviews are held via MS Teams, the combination of your self-assessment that you give and the person specifications, this is something you definitely have to read about if you're applying for radiology. So there's a person specification for this year which has been released. So it includes 2 criteria. One is the entry and one is the selection criteria. So the entry criteria is the essential criteria, and the selection is a combination of both the essential and desirable criteria. So going into detail, your entry criteria, obviously you need qualifications, which is or equivalent medical qualification. You need to show eligibility, which will be either 12 months. You need to show your full GMC registration by the intended start date, and also you need to show evidence of your competencies. Like I told you before, it will be your FI2 competencies if you're in a foundation program, or otherwise it will be your CREST competencies. And fitness to practice, again, this would be via application form and references. They'll be able to check that. Your language skills, you need to have adequate written and spoken language skills. Then they would check your health. Again, this is via your application form will have a few questions as well as your pre-employment health checks and career progression. And there'll be questions regarding your employment history, which will be in your application form. They'll cross-check with your references as well, and you need to show proper evidence of your career progression if you're in a current training. Next is your selection criteria. So this is, again, like I said, it's a combination of your the essential criteria and some desirable criteria, which obviously gives you additional points when you're in your portfolio. So in addition to the basic MBBS qualification, if you have full MRCP or MRCS, MRCPCH, or any intercalated BSc or equivalent qualification or higher degrees like MSc, PhD, or MD. Then they'll be checking your clinical experience. This is they need to make sure you have experience in a range of acute specialties. This will be via your exams, your application form, as well as your interview. Clinical skills, they'll be checking your clinical knowledge and expertise. Make sure you have sound clinical knowledge and able to manage uncertainties, able to work and without direct supervision. So again, this will be checked by your exams and the interview as well as your references. Academic skills, research, audit, teaching. So you need to, if you have QIP projects, audits, any teaching, all these need to be, you need to provide evidence for this. This will be again via your self-assessment as well as during an interview. They do ask questions in the interview regarding to understand your understanding of audits and research. They do ask questions related to that. Going to personal skills. These are a number of skills which usually get tested during the interview, mostly because though the interview is 15 minutes, they try to bring in all of these in order to test your communication skills, your problem solving, decision making, empathy, sensitivities, your leadership skills. The other way you can show this is via, if you have a multi-source feedback, you can upload this during your evidence uploading in order to show these skills. Then probity, honesty, ethical dilemmas, confidentialities. So this will be again with your SJTs during your exam and during your interview. They do ask specific, they give you a scenario where they want to check your professional skills and your kind of patient confidentiality and all of those skills. Then this is again a very important topic that they do ask during the interview, your commitment to specialty. So here they specifically ask questions regarding to understand, to get to know how much you understand what you're getting into. So what do you know about radiology, why you want to do radiology, and you also need to show commitment to personal and professional development. This will be through kind of audits, teaching, your exams, evidence of self-reflective practice. This is something that you can upload with your evidence. So if you have any, you can do a reflection on your teaching, any reflection on any particular patient case that you felt was useful, which matches one of your skills. You can upload that. Evidence of time spent in radiology. So this would be your case session, or if you had a rotation during your foundation years, that would be included in this. Understanding the role for consultant radiologists. So as you've had the previous talks, if you kind of note that down, and they might ask you questions regarding that as well. What do you think about what do you know about life as a radiologist? So that would be something useful to read about. Then you need to also understand the structure of the training and the potential careers in the training. So you need to know about, they might ask you questions about the exams in radiology and how the training works. You also need to know about the opportunities and threats to the career in specialty. So for example, in radiology, what are the possible threats in the future, or what are the current threats? That are questions that are commonly asked during the interview as well. Extracurricular activities, achievements relevant to the specialty. So this would include your QIP, teaching, or audits which you've done in radiology. So there you get marks as well. And evidence of participation in meetings, courses relevant to specialty. So you can do kind of attending conferences or like courses like chest X-ray courses. All of those you can upload your evidence, and that will give you additional marks as well. Interview, as told before, it's held online via MS Teams, and it's booked through Oriel. So once you've completed your MSRA exam, they'll let you know when the interview slots are available, and you just need to do immediately. It's first come, first serve basis. The interview structure, because it's held online, is just a 15 minutes station, just one station, and most of the questions here are based on your personal specification, which we just discussed. So just go through that, read that, and make sure you prepare your answers for that. The commonly asked questions are your commitment to specialty, knowledge and skills, and ethical scenarios. So they definitely, last time when I had the interview, they did asking about this, any kind of a scenario where one of your colleagues is under the influence of alcohol, and what do you do and how do you manage that situation? During the interview that they assess your commitment to specialty and as well as your communication skills. And the final selection score will be a combination of your MSRA score, your verified self-assessment, and the interview. Choosing a deanery. So like Sanjeev spoke before, in addition to the clinical radiology post, there's the academy post as well. So with Radiology Academy, it's more organized and scheduled teaching. Like he said, there are at least 3 months of teaching before rotating into clinical attachments. In traditional radiology, it's more of learning on the job, but you do have teaching as well, at least 1 day of organized teaching directed at the FRCR Part 1 exams during your ST1. Then this website called is Society of Radiologists in Training. So it's a registered charity which was established in 1993, and they organize yearly conferences for radiologists in training. They also welcome foundation doctors and medical students to attend and present their projects here. You can have a look at their website. They are available on social medias as well. You can go have a look and you can join them as well. I'll pass it on to Hina for this. Thank you.
Hello guys, so my name's Hina. I'm Clinical Radiology Teaching Fellow and ST4 at the moment. So a couple of things in terms of advice for when you guys are prepping for your portfolio upload and the MRSA exam and your interview. So one of the big things is there's a lot of information to take in from your personal specification, and it's a good idea to print these out and jot down some of the scenarios that you can think of that relate to yourself. Now, even if you're not applying this year, this is a very good thing to do, so you can work out what sort of evidence you need to upload and make sure that you have these ready for when you do want to apply. And if you are applying this year, you want to make sure that you've covered all bases and you've not forgotten to upload something. So always have a checklist with you. Now, the personal spec also helps in your interview. If you jot down some of your examples, if you write down some of your scenarios, you can practice these with your friends and just get comfortable talking about them, because interviews are fairly common in terms of what they usually ask, and you will most likely definitely be asked why radiology. And you want to have a good structure to answer this question. And so if you've written down a couple of examples of what you've done that's related to radiology, then you'll be able to use that to flow into quite a nice structure of an answer and score really, really highly for your question. So aside from the personal specification, you guys have to do an exam. Now the exam is done for multiple specialities. It's a generic exam. It's usually described as one that you can sit after you finish medical school. There's 2 parts to the exam. There's an SJT flavour to the exam, and then there's the actual medical question. Now there's lots of different exam banks that you can use to practice for these, such as the MCQ bank, Past Medicine, Past Test. So there's lots of different resources out there that you can use. And if you have any questions about the resources, put them in the chat, because Mahima can talk to you a bit more about them. But the SJT is covered in this as well, and it's important that you guys look at these, because not only do you get assessed them in your exam for the SRA, but also they've started using some of these questions in your interviews, and your interview will include an ethical component. Your typical example being your colleague came up one day and smelt of alcohol. What do you do next? So try and look at all the resources, because they do overlap with each other, from the exam to the portfolio to the interview, and you can get a lot out of one resource for all 3 things. On the day, try and clear your mind, get an early night, have a good breakfast, be confident and be positive. There's nothing better than seeing someone that can present themselves really well in front of a consultant in an interview, to show that actually you know what you're talking about, this is what you want to do, and this is where you want to be. So good luck for your applications. If you have any questions, please do pop them into the chat and we'll get them answered.
These are some links that you can have a look into, and they give really good information on the training program and how to apply regarding the exams and the interviews. Thank you. Any questions?
So the first question is the evidence upload deadline different to the application deadline, and where do we upload it? So Maima, if you can just put your slide back up as well.
Oh, okay, sure.
For the time scale. So yeah, there is a different deadline for the application and the evidence upload, and we'll just bring up the timeline for you to see again. And uploading, you upload everything onto the Oriole system. So as you go along and fill out your application form, you will find one of the sections will be to upload your form, upload all the evidence.
So yeah, so the application period is between 4th November to 1st December, but you upload the evidence between the 17th and 7th January. So it is via Oriole. Once you finish your application, they will send you a email to remind you regarding the evidence uploading. Any other questions?
So the next question was, what do you think of radiology academies versus traditional programs? So I'll take this one. And the two of them have very different approaches to teaching and learning, and that's the biggest difference to them. And it really depends on how you learn best and what you think you will achieve the most out of as to which one you choose. Now, there is a great drive going towards academies, and there's a lot more academies being developed in radiology. And this is purely to increase the number of intake that we have. Now, as you can imagine, teaching a group of 20 trainees in terms of an academy with cold cases and lectures is going to be a lot easier than having 20 trainees on clinical attachments running around the hospital behind a radiologist. There's just not enough radiologists currently present for us to have one-to-one attachments. And so slowly all of the programs are trying to move to the academic type of program. But each academy is very, very different. So in some of the academies down south, you have full programs of 9 to 5 for a full 3 months, as mentioned, and then you go on to clinical attachments for 3 months and then back into your school life 9 to 5. If you look at Leicester's academy, we currently do two full days of teaching and then 2 half days of teaching. And the teaching varies between your Part 1 FRCR exams and general radiology knowledge. Now, regardless of which program you do go on, you will have Part 1 teaching. It's just the format of delivery you have for the actual general radiology knowledge. And some of this is more ad hoc as you do reporting compared to cold casing first. So it really depends on what type of learner you are. And the other thing to think about is, where do you want to be? So the academies are quite infrequent at the moment. I think there's probably about 6 of us around the UK. So it also depends on the location you want to be at. So there's only a selected number of academies, and if you have a location elsewhere in mind, then that might not fit in that sort of boat either. The next question is there a certain amount of points you suggest to have regarding the uploaded evidence? Now, for any recruitment, you are advised to have the maximum number of points possible. And so I would print out that self-assessment form and have a look at where you have evidence and upload it. And if for some reason this time around you don't have enough of points, you should still go for the application. It doesn't hinder your chances next time, but at least once you've gone through the application process, you might have more points with your SRA exam and your interview, and that might pull you over the edge. So it can still work even if you don't have the full points on your self-assessment form.
Brilliant, thank you. So we also had some questions from the sign up link.
Yeah.
So one of them was that we tried to answer earlier was, do you know anything about radiology training abroad? I don't know if you will.
I personally don't. I'm not sure, Mahima, if you've heard much about radiology abroad.
No, I don't as well. I know in India, but that's a totally different pathway. But I'm not sure which country they mean.
Sorry, guys, I'm afraid we don't know much about radiology abroad. But what I can say that is some people that come from abroad, having done their radiology training, still need to do some of their competencies here, particularly if they've not CCT'd in their own home country. And I presume it would be a similar format where there is likely to be some form of competency completing once you've moved across, unless you've done a complete CCT here.
And the other one was, are there any courses or any specific work experience that you should look to include in your CV?
So you should have your taster week in radiology. This is a minimum of 3 days at the moment, and that is an essential thing to have for your portfolio. I suggest if you haven't got it for your portfolio, you try and get it in the next couple of weeks. In terms of courses, there isn't that many courses that you can go to, but there are a couple which show your interest, and that's the most important thing. So if you are an F1 or an F2 rotating in E, most of you should be advised to go to the Red Dot courses, and they're on plain film. They're usually hosted by Norfolk Park Hospital in London, but they are done online virtually these days. And they're quite good at combining your acute knowledge with radiology. So it's good to have a mix of it complementing your F1 and F2 days as well as your radiology training. Apart from that, I don't think there are that many necessary courses to attend, but the SRT, as Mahima had shown, has a lot of courses and presentation conferences that you guys can present your audits on. So if you have any current QI and audit projects, actually presenting them in radiology conferences is a very good way of getting your exposure, getting your points for radiology conferences and for presentations. So that's a very good one to choose if you do want to present something and also get points for it. Is it possible to get experience of radiology outside of taster days? This is potentially possible, but it really depends on the department that you ask for. So, for example, in Leicester, we have a program. Oh, I'm echoing.
Hang on 1 second, let me fix that. Yeah, try again now.
Okay, so yeah, so radiology taster days, usually they do as a set program. In Leicester, where we are, we have a 3-day set program that when you guys apply for, you roll on to straight away. In different departments, they'll have different taster programs that they do. Now, if you can't manage to get a 3-day taster together, then it is worth doing sort of 1-day tasters at different times, but then combining it into a 3-day. So you have to have a certificate at the end that says that you have done 3 days, even if it is 3 separate days of radiology. So yes, you can get it outside of taster days.
That's brilliant, thank you. So guys, unless there are any more questions, I think that's it. I've put the feedback form in the chat again. Please fill out that feedback form. It's really helpful for us for designing events for you, and really helpful for all of our speakers, so we can give them some feedback and use that for their portfolios. If you had any other questions, feel free to put them in the chat, or if you think of any at a later time, then do email us. Here we go. So someone's just said, in which section of the self-assessment form do we mention the additional courses that we attend?
So you can upload that during your evidence uploading time. So if you have a chest X-ray course or any teaching course, it gives relevant headings when you upload your evidence. So you can upload it during that time under whichever relevant part it includes. For example, if it's teaching, then you can upload on teaching, or if it's related to radiology, you can upload on the commitment to specialty.
Yep, so the first of research into career in radiology is one of the best ones to put that into. So that shows you your commitment in radiology. So you can attend that one in the research into career in radiology section.
Okay, I think that might be it for all of the questions then. So thank you very much for. I hope that you enjoyed today and learnt a lot. We have recorded the session, so we will be discussing how and when we share that with everyone. And yeah, in the meantime, please fill out the feedback form. If you've got any other questions, then feel free to email us and we can pass it on to the relevant people. Thank you for giving up your Sunday morning, and we hope that you have a lovely day.